This conference will now be recorded.
Okay, Terry, go ahead. Don't forget to unmute your line, Terry, *2.
Right. Well, welcome everyone. We're expecting some other folks to join us, so why don't we begin? You know, the topic of the day and this discussion is going to center around the areas of workforce and community, customers, and population health. And kind of in that regard, it's a really very kind of a full agenda for discussion today. A lot of what we had talked about, I think, in the last webinar had surrounded the population health pieces, and the center just released a population health document that we hope you have had an opportunity to take a look at. But in essence, I think some of the pieces of that document were incorporated into the presentation last Wednesday. And this discussion is going to center around some of the kind of key elements of that population health, looking a little bit at some of the workforce issues as well, talk a bit about the community aspects of our FLEX program, kind of what's going on in our states, and also in context because we have this hospital that is out there that we've been using kind of as an example, how we might be able as state FLEX programs to help a hospital that might be in crisis, so to speak. What can we do to improve the performance of our customer service in our hospitals, you know, which is reflected in our HCAP scores, et cetera. And so I think it's going to be a really good discussion. I'm really looking forward to some of the things that you folks are going to be able to share kind of as we move forward. I think to begin, what we'll do is, why don't we all just kind of introduce ourselves? We've got a number of people on, and why don't we start out with, Angie, you want to start? And again, hit *2, and then what I would appreciate is everybody else would give us their name and the state that they're representing.
Hi everyone, this is Angie Emge at the Michigan Center for Rural Health. Is that all that I needed, Terry?
That's all. Yep.
Thank you.
Gloria, you want to introduce yourself? I know who's on, but I want everybody to know.
Sure. This is Gloria Verme, and I'm at the State Office of Rural Health. Good afternoon to everyone.
Hi, Gloria. Anita?
Hi, I'm Anita Lovato from New Mexico.
Hi, Anita. Curtis? You have to hit *2 if you're... Okay. Megan from Texas.
Hi, this is Megan from Texas.
Hi, Megan. Scott, you're on?
Yeah, this is Scott Daniels with the Hawaii Office of Primary Care and Rural Health, and I am on.
Terrific. Hi, Scott. Katie.
Katie Jerkins with Iowa State Office of Rural Health.
Okay. Is there anybody else on the call that I didn't mention?
Did we get Kenny Stappenberg?
Yeah, this is Kenny from South Dakota.
Hi, Kenny. And then Nicole is on, and I think Margot Colsa from our staff is on as well. So welcome, everyone. As I mentioned, we're going to go through, let me just run through my very brief little presentation here to tell you about the objectives. We're going to talk about the second exercise. Now, one of the things I want to tell you is that this, as I think I told you last time, this is a real hospital that I worked with years ago. What I can tell you is that today this hospital is probably one of the best in their state. What we were able to do and what we discussed last time is we started with the leadership and strategic planning, But with this hospital, helping them put together a strategic business plan in the course of our consultation, getting the leadership aligned, et cetera, we were able to kind of enlist the help of an economic development agency in that area who recognize the economic importance of the hospital. And we're able to give the hospital a $500,000 loan, very low interest. I'm not sure if they ever paid it back as such, but one of the reasons I'm bringing this up is that I think it's also relevant to the conversation in terms of, in other words, if this hospital was truly as destitute and as kind of broken as the model here, the very thought of doing community assessment at this point might not be something you put on their agenda. But now as we're going to discuss the hospital, let's assume they've got $500,000 and, you know, I think that makes some of the discussion a little more relevant. Let's also assume that they've reached out to the state flex programs, and that's part of what we want to be talking about today. And then we just want to get your feedback on both this hospital and also get some examples from you folks that you can share amongst yourself in terms of things you may be doing in each of these key areas of workforce, community, customers, population health. And then the other pieces that came in here were partners and networks as well. Okay, there's the agenda. Again, let's review our performance excellence framework again. And it basically, we're operating under the concept that it's going to take a pretty systematic, holistic approach to get this hospital, or in my opinion, any critical access hospital, to go from you know, either crisis or a situation where they're going to be severely challenged, which you could say most hospitals are going to be, into sustainable performance and sustainable excellence, which probably should be the goal for all rural hospitals. And as we discussed last time, and as you've seen over and over again, we're using a strategic framework that basically has now been recommended, I think I told many of you last time, by the President's Council on Healthcare and Technology. In their May 29th report, they specifically made a strong recommendation to the President and the Department of Health and Human Services that healthcare providers use the Baldrige framework or a like systems framework basically to ensure that holistic approach along the way. So in that regard, we've at least been timely with the President's Council. But I think we also feel pretty strongly that a strategic framework is important, and I think, as we discussed last time, it doesn't necessarily have to be Baldrige. The Studer Group has an excellent framework, and we'll talk a little bit more about both of these frameworks as we're going through. And then this is our case study of Community Memorial Hospital, and we asked you to tell us what type of interventions would make the most sense, kind of based on your experience and kind of based on your advice moving forward. It was interesting because as we break our results down into the cohort sections, there was probably the strongest recommendation certainly of all their cohorts. And Nicole, you've had a chance to look at the various cohorts. Would you agree that our Group A has the strongest recommendation on partnerships and rural healthcare networks?
Yes, this group definitely felt very strongly about what they chose.
Yeah. And so I want to spend some time talking about that, what might be happening kind of in other parts of our country in terms of the states. Are we seeing more consolidation? What about the systems? I'd like to just bring that topic up right to begin with. What are we seeing in terms of our hospitals kind of moving into networks? and I might just call on you, or I really would invite folks just to speak up if they will. Let me just ask this question. Are we seeing better performance coming from our hospitals that are aligned with systems, or hasn't it made much difference? Angie, what do you think about that? You've got a number of different systems, and I noticed, for example, up in the UP, you have a system, I believe, isn't it out of North Carolina, that has moved up there. There's a number of besides, Angie's got this quality network where they've networked these hospitals together, but I'm just wondering, what are you seeing in terms of the systems themselves?
Well, yeah, that's a for-profit in North Carolina, by the way. It's, I forget what it's called, but it's for-profit, and a number of the other hospitals are aligning with others rather than the for-profit, by the way.
Very interesting. Somebody just asked me about that today, actually. So, thanks.
Someone did ask you about that?
They did. They just said, "What am I hearing happening up in the UP?" And
yeah, well, they're not embracing the other 10 hospitals aren't really embracing. The Bell Hospital that's real near there, of course, they're owned by them now. So it's being a for-profit, I think they're just kind of moving away from that. And now I forgot the question.
Well, do you see that the systems hospitals, critical access hospitals, are performing better than those that are not affiliated?
Yep, absolutely. There's no doubt.
Okay.
A couple of the hospitals that are not affiliated, I was up doing visits, and they are expressing some extreme distress, and the other affiliated hospitals are not.
Interesting. Very interesting. Scott, you've got a network. I mean, all your hospitals are in the same network in Hawaii. What do you see as the advantages or any of the challenges that might be caused by these networks in relationship to your Flex program?
Well, the plus is that we can usually is that we're able to address within the network sort of the common problems that are affecting all the hospitals. But the other advantage that the network provides is basically the ability for the performers basically to share what they did with the other hospitals, which is actually nice because it shows that this isn't just coming from the consultant, this is coming from your peer, and they're able to, they implemented this and it was effective. So it has that added weight of being effective with someone who's actually in the business. The biggest problem we have with the network, at least in Hawaii, is we have 8 hospitals in one system and 1 hospital that's not in that system. So we have to really be careful to make sure that it doesn't become merely focused on the one large hospital system. And make sure that we always make sure that whatever gets discussed relates back to the one hospital that's not in the system. So that's the only disadvantage that we've had with the network, and that's just carefully making sure that discussions, when they start going off the rails, that or when they start getting too focused on the one system over the other, that we direct it back so that it includes the one hospital that's not part of the larger system.
Okay, thanks, Scott. How about anybody else? Anybody else want to comment on kind of the roles of networks, both positive or negative, in their state?
Hi, this is Gloria. Can you hear me?
I can, Gloria.
Okay,
yes.
Great. Sometimes my headset doesn't work. I'll just make a brief comment about Iowa, and you know that we have a ton of CAWs, 82 of them, and we have large systems, Unity Point. We have 6 Mercy systems, and the Mercy Des Moines has networks within it. And then we have Avera, Allegiant, and Gunderson, which actually are in other states. There are border states, but they have CAUS within Iowa. And while I agree that the majority of those are performing better and getting into ACOs and doing better quality work, it still comes down to leadership. And as I talk to some of the individuals that are in charge of networks, you know, every time they go back to the leadership of that particular hospital. So I guess that's a caveat I just kind of wanted to emphasize is leadership development and management, you know, still pull a call through whether they're a part of a large system or not.
Oh, absolutely. So, and in some cases, what we see is I mean, it's the same sort of thing I think you're saying in terms of the networks themselves or the systems themselves, where they have leadership that, you know, are going to be supportive of the rural hospitals or put a priority on their participation. Those systems are going to perform better. We have seen some pretty miserable performance from some of the systems that are out there. And so it really does boil down to, I think I'm agreeing with you on that, to leadership, both at the hospital level, but also at the network and the systems, big system. I make that differentiation just in this discussion. Is I think of the bigger systems as the Averas and the Mayo has a system, and they're all over the place. But a lot of the networks, and Pat Scow, I notice, has joined us. So Pat, I know you have your hospitals in one big network in Illinois that you have led for years very successfully. What's the interrelationship? I assume a number of these hospitals are members of systems as well. Does that create problems? I'd just be interested in your experience. And you can hit star too, Pat, if you're still on. Well, for whatever reason, Pat's not on. Kenny, I'm going to turn to you now because you have two big systems in South Dakota, Avera and Sanford, both of them with a substantial number of rural hospitals. Can you give us an idea? Do you work closely with your bigger systems? Do you see those, both of those systems actually providing a good deal of support to your hospitals?
Yeah, and we actually have a third one out in the western part of, say, Rapid City Regional, which are most of the CAUS out there are either part of that system or, the couple that aren't partner pretty heavily with them, and they manage a couple in Wyoming too. But yeah, most of my larger projects, I start out, I hit the systems up first because I know, I need support from them, and they do provide me a lot of support, and I actually provide quite a bit of support to their hospital. So it's a pretty mutual partnership I do with them. And actually, I invited them to the table when Sally Buck was here a couple weeks ago for a site visit, because I do partner so much with them. But one of the things I was going to mention too is, even though it's been a major advantage to have these systems, is one thing is has happened here too. Is sometimes we have a call where we've had the same CEO there forever, and then if that person retires, sometimes the younger people that come in, they see ways to advance within that system. So they go to maybe a rural place for a while, but then their idea is to start out there and then get promoted within the system to another position. And sometimes then we have, kind of quick turnover in some of these places after a while.
That's an interesting concept. That's right. So in essence, that if they're part of the Sanford system, they may be transferred from one hospital to the next.
Or even to the corporate,
Yeah, yeah, absolutely.
And that happens with not just CEOs, but sometimes the DONs and other kind of leadership type people too.
This is Pat, but that may not be the only answer out there. There are a lot of states have multiple systems out there, and they may not necessarily want to be a part of a system. So,
absolutely, Pat, and that's why I was thinking that there seems to me
you don't want to just pass it off to the system and let them fix the problem, because we don't know all the final solution to it all.
Absolutely. Talk a little bit about your relationships with your systems, because you've got a number of members I know that are part of systems, and talk a little bit about your experience dealing with them as a network.
Okay. Yeah, happy to. I think systems are great, and they work well for different hospitals at different times and place, and depends on their location. But there are also times where independent hospitals, they prefer to do that. Maybe they're in between 3 or 4 different systems. Their physicians tend to be a little more independent. They have concerns about losing some of their local identity and primary care. So as a network, we have to support both models, because the systems rely on Flex and the organization that we have for information about critical access. They don't really need us so much for management decisions, but really to support the critical access hospital staff and education and things like that. For the independents, they tend to remain independent. They need a lot more assistance with physician alignment and things like that. But it isn't the total answer. There's some nervousness among hospitals that are independent, not knowing what the future might be. So they want to, look at their options to remain independent as much as possible. And sometimes through networks or through management companies, it allows them to be able to do that and have that support. I agree. Was that Kenny that, was talking about, the value of the system of being able to move through and that. But, networks and other things provide some other types of opportunities. I don't think they could have just one answer for that.
Yeah, I totally agree with that. In essence, I think at least my observation is that we're seeing a significant increase in both the number and the value of networks. I think hospitals in general are recognizing that they're going to have a very great difficulty existing by themselves. And I think those are the choices that they have, that there are some really excellent networks out there, or they can create a network with other organizations if there aren't networks in their state. Or they look to the bigger systems, but both are viable options. There's some pretty poor systems out there, so there are some pretty ineffective networks that aren't doing a whole lot at this particular stage. But and again, let me know if you disagree with this. But in essence, I think we're just recognizing that independent hospitals are going to need access to the volume discounts to, if they're going to be doing anything in the value-based models themselves, they're going to need partners kind of moving forward. Does any state out there really feel that there's a significant number of their hospitals that feel that they can remain truly independent all by themselves? And I'm not talking about in a network, you basically are able to have more independence probably than you are with systems. But any states where you just see a real pushback on either being a part of a system or being part of a network?
Terry, I think some did. Oh, go ahead.
I'm sorry, Terry. This is Melissa, Missouri.
Yeah,
I would have to say that is one thing that we do kind of struggle with here in Missouri, is this whole idea in and around networks. I would say I have a third of my critical access hospitals truly feel that they can get by independently. I would say our critical access hospitals are split up into thirds, which would mean like a third of them are owned by a bigger system, a third of them are really closely affiliated with other big systems, and then a third of them are truly independent. They don't want anybody coming in and trying to do network with them. And those are the ones I think I really struggle with as far as getting them to understand the importance of, and the fact that they're going to have to partner with somebody eventually.
That's, you know, that's kind of characteristic of Missouri, isn't it? I mean, that's my observation at least. They're pretty independent.
There's a reason why our state animal is the mule, and because we're very stubborn. And I know that's just, yeah, something that, you know, I've made it a priority to try to work on in this next year is just trying to get, and it's not just the critical access hospitals. I have a lot of rural health clinics that way as well that they just don't see the importance, I guess, of developing those strong ties and those networks.
You know, another state, Megan, I'm gonna call on you. Another state that doesn't seem to have to be. They seem to have a lot of independent hospitals out there. Is Texas? Megan, are you finding that as well? Does there seem to be more support? Now, all those hospitals basically are part of Torch, so I guess that to some degree it's a part of it. But Torch is kind of an association besides being a network as well.
Right. Right. We're actually having our CAW conferences tomorrow, and we're going to bring up the topic of SHIP networks and try to work with Torch and talk to the hospitals there to see how we could work better and what they want. But yes, there's a lot of pushback from that and negativity. They think, you know, that networks are going to diffuse the help they get from us sometimes, and then although I think it can only improve it when we have 79 hospitals to work with,
right.
I see that it can be definitely a benefit, but we're kind of just starting the official conversations about it. So we're hoping for some good response and feedback from that.
Good. Hope so. Good luck with that.
Thank you. We'll need it.
You and Melissa can commiserate.
Yeah, it's probably very similar to Missouri.
Terry Curtis had a comment in the chat box, too, about New Hampshire.
Who did? Curtis?
Curtis? Yep. He said that he thinks all of the New Hampshire critical access hospitals are looking for who they will join or varieties of partnerships to remain viable.
Okay. Yeah, and there's been a lot of ACO activity up into that area as well. Yeah. Any other comments on the networks? That was far and away our number one suggestion for this hospital, that it look at either going through a network or a system, finding some sort of affiliation, some sort of access to kind of network services. The other reason is kind of the care transitions piece, the data sharing, et cetera, came up as well. Let's talk a bit now about the community. And the number, there was a tie for, for second on community health assessment process that, and I look at this as broader than just a community assessment, more of a community engagement process. In other words, there's a lot of people in that community that are leaving the hospital, maybe for good reason, because it looks like it's less than excellent hospital. But on the other hand, if it's going to change, it's going to have convince the community, or if it's going to survive, basically, it's going to have to convince the community that it's viable, that it is a source of good services, et cetera. And at least our experience working in well over 100 communities doing community assessments and community engagement work. In fact, it's probably closer to 150. We lost count a long time ago. Is that the community basically isn't fully aware of the services that are available, and conversely, the hospital is generally not really aware of what the community wants and needs, and in essence, may not understand why community folks are leaving and going to the bigger centers. And that's the case both in the troubled hospitals and the really good ones as well. Community engagement becomes a real opportunity, I believe, at least, to kind of improve the financial bottom line through just providing more services, better services, et cetera. But let's kind of turn to that and kind of what's happening on that kind of community engagement front in your states. Anything you want to report or share with the group?
Terry, this is Pat in Illinois, and a number of our hospitals have done the community needs assessment as non-for-profits, and surprisingly, even a number of our district hospitals. I think there's been an overall effort in Illinois to bridge the work that the health departments are doing with the hospital community, and I think it's really important. However, I do suggest that hospitals, when they engage in that, they need to be ready to hear the information and kind of have their act together. You want to have good, you don't want that to be your only thing that you're going to do in this situation. So, but I think it's wise, and I see it being part of the hospital process, into the future. I think it's not just it's not a flash in the pan. I think we're going to use it more and more, and hospitals going to have to rely on it and fine tune it, but also work with public health and other groups. So that's just my feedback.
And Pat, one of the things that I don't know if everybody knows is that your network has applied to be an ACO, and kind of in that regard, it becomes, population health becomes a kind of a major concern here. Talk a little bit about just kind of an update for the rest of the folks on the call about kind of what you're doing in that area, and what's really going to be key to being successful in that ACO, particularly in regard to the community and care coordination.
Yeah, it's our hospitals realize that this is something that they're going to have to do. We started about a year ago looking at population health, and quickly from there the hospital said, what you just mentioned, and several of you mentioned, that they can't really go it alone. They need to partner with somebody. They can remain independent, but they need to partner, and they realize that they don't have the resources. So sharing and learning with the community, that's why we moved into the ACO process, Medicare Shared Savings, to give them an entity to work from those that wanted to remain independent. And, population health, I think, care coordination, and for those to be viable, you have to, from a legal standpoint, be able to show evidence of clinical integration, coordination of care, and, and getting the physician buy-in and overall savings, so other entities who want to contract you will be important in population health management. And, our hospitals don't have the resources, so partnering with other groups will really be important. And, we hope to have the application done the end of July. Obviously, that's the due date, but it's a real learning process, and not easy to know what your community wants. And, in doing that, one of the things that we're learning is that we may have to do some sharing among the hospitals. If there's a couple of hospitals in the area, why doesn't one have home health and the other one have, a long-term care unit, and have some sharings like that. So, watching at cost and trying to still meet the needs of the community without trying to provide everything.
And in essence, in terms of the care coordination model, another area that comes up in the sector is the development of partnerships, which again came up high on the list of importance here. What type of partnerships would a critical access hospital kind of moving into an ACO like the Illinois hospitals are moving, what type of partnerships would be really important for them?
Partnerships that we'll look
Yeah,
for.
I mean, what type of communication would need to take place, particularly in the care coordination side of it?
Yeah, we're as we're building it. Obviously, you have to work with, you have care transitions, which goes from one level to the next. And I know we're going to participate with Blue Cross and Blue Shield with their intensive medical home model, where Blue Cross and Blue Shield, they're going to identify their high-risk employer patients. Blue Cross and Blue Shield, their own particular patients, and then we will develop nurse care coordinating teams, and they'll be set up in pods. And so, the partnerships will be what we'll need with pharmacy and social services, home health, all those things, so that we keep the cost of that patient, the high-risk patient, chronic disease patient, down and start to build towards, best population health. I don't know what you're specifically looking for, but the key, I think, is the most important is the partnership that has to happen between the hospital and the medical provider. And we've struggled with that over the last several years, and, for real to survive, they're going to have to partner with their physicians. So that's probably the first partnership, and then build out with your medical neighborhood.
Right, and particularly if you're looking at post-acute care, it
Right.
could be that the hospital might provide some of that. There's a really interesting model that the Mayo Clinic did with its 11 or 12 critical access hospitals when they were actually doing post-acute care, what would have been traditionally been long-term care services kind of in the hospital itself. And so, their results showed better quality and better financial performance for the hospitals. But in lieu of that, then we're talking about getting patients out into the long-term care facilities, either nursing home, or assisted living or rehab centers, or et cetera. And then the other piece that comes in here seems to be another really strong one is the mental health side of it as well, kind of providing those support services. And as an ACO or an accountable care organization, it's going to be almost it's impossible to be financially successful and not be able to reach out into those partnerships. So
that's right.
It's the right thing
and even
to do
palliative care, Terry, will be really
absolutely
important to provide care at the most efficient level.
Yeah, absolutely. Who else is doing something in this area that's been successful? Or
Carrie, check your chat box. Curtis had another comment about CHNAs.
yeah. And Curtis's thing is, I began to wonder if the CHNA process will begin to be very political, and who drives the process may drive results of needs to bolster activities for which they could get paid. And he says, kind of cynical, but some real questions about that. Actually, let me ask you, in Michigan, kind of what's going on the community side. Are you identifying some hospitals that are doing really extraordinary work with their communities?
Terry, I'm not sure about that. I think there's an effort in the Thumb region to coordinate their community. They've done community health needs assessments. Now they're, I think, working through their Thumb Rural Health Network to identify some of the most important areas that they have. And other than that, I'm really not too familiar with what's going on.
Okay, thanks. Scott, in Hawaii, I know that's a very community-oriented, from my recollection of being out there and speaking with you as well. Um, anything to report on the community side of it? Anything that's innovative?
Well, I don't know about innovations, but one of the things that's been important about community health needs assessments out here is that um, it works both ways. I mean, not only does the hospital find out what the community feels that needs, but the community, at least that's in attendance, finds out the services that the hospital actually has. More than once, we've been in the community, and the community goes, oh, well, we'd like it if the hospital did this, and the hospital goes, we do that. And it just gets back to my point a lot of times with the hospitals here is that they have to do a better job of basically getting the word out and advertising themselves on what's there. But by and large, the community needs assessments, I think, at least in Hawaii, have done very well in the communities that we've done them in. So,
Okay, good.
Terry?
Yes.
Hi, this is Gloria in Iowa, and I kind of wanted to talk a little bit about Henry County Health Center. That's one of our critical access hospitals, and they were the recipient of the NRHA Outstanding Rural Health Organization Award this year.
Great.
And one of the reasons they got it was because of their community assessment, and they were able to really step in and give some more support to that community for their Close to Home campaign, which was just an overall campaign to boost their health and economic well-being and infrastructure within their community. So Rob Gardner, who is the CEO down there, talked about, that partnership and how it all came together, but that could be one example of it happening.
Yeah, that's a great example, Gloria. I really think this is such an underappreciated area that would be of huge importance for a variety of different reasons. But one of them, I think it's huge in financial advantage for folks if they would more actively engage their communities. Their story is, is not really that well known out there, and it really gets into also preparing these hospitals to take on more of a wellness, prevention role as well. And that's maybe the last topic on the community side I wanted to bring up. But is anybody seeing really stellar wellness programs developing in the hospitals themselves? Because here, this to me is a double win for rural hospitals. A, they can reduce their health care insurance costs, and you folks know hospitals are not particularly a healthy place to work if you take a look at the health outcomes of their employees. Nurses tend to be slightly unhealthier from what I have seen of the research than the general population, et cetera. And the possibility of bringing in programs to help these providers deal with stress, deal with their own problems, their own issues, to do care coordination actually of the employees themselves when they get sick, et cetera, seems like just a perfect opportunity. The second big win of that, not only does it lower the healthcare costs, well, I'd say three big wins. Secondly, you're going to have much happier and more capable employees. But the third big win is that in essence, you prepare the hospital for taking on this role of population health, which inevitably, I think we believe it's going to be moving into. Are there examples in your states where you're seeing some programs like this really take hold and wellness is being embedded, and health, kind of the public health model is being embedded actually in the hospital employees. Well, unless we, everybody's shy to talk about, I don't know a whole lot. There's several. A friend of mine who runs a hospital in California has instituted such a program. In fact, he was just out. We're actually at the current time holding the Minnesota Rural Health Conference and the Critical Access Hospital Conference here in Duluth. So we actually had this hospital administrator come in and talk to our critical access hospitals about what he has done kind of in the community and in his own hospital is kind of trying to set that example. So I think that's one of the things that task is going to do, is to try to kind of identify, maybe if you folks would share examples of these initiatives in your hospitals. Again, we could start developing some prototypes and models that perhaps others could use as well. Because at least from my perspective, it's absolutely the right thing to be thinking about right now. And I know there's tons of other things to be dealing with, but I wouldn't miss an opportunity to bring this in, because the initiative will absolutely pay for itself from everything that we've seen in the research. Let's move then in the last like 15 minutes we have to the workforce itself. And again, I don't mean to diminish that importance. It's obviously crucial that our critical access hospitals have a stable workforce, that workforce be motivated to provide excellent care, that the workforce be change ready, etc. And I'd like to maybe hear from some view about what is actually happening in terms of culture change in the hospitals, what sort of programs you might have seen out there, what could our community memorial hospital perhaps look to kind of motivate the employees and make sure that they're, whether it's education, change readiness, whatever. Any examples that you'd want to talk about, or things that you're thinking of doing in your Flex program moving forward?
Terry, this is Angie.
Hi, Angie.
And can you hear me?
Yeah, I can.
Okay. A lot of traffic has been coming up with the quality network, and they get on different topics. And recently, a topic has been, I think, with the nursing staff and with the hospital employees, what kind of things, they'd like to know what types of things other hospitals are doing to recognize their employees, different, just different types of activities. And that leads me to believe that they're starting, or not starting, but becoming more involved in employee happiness, wellness, etc. So that's what I know.
Interesting. Yeah, it's, every time a nurse leaves, that's the information that I have is it's going to cost the hospital close to $50,000 or more. I've seen another study that says $60,000 to replace that individual. Whether it's they're going to have to recruit, they're going to have to train, etc. So anything that could be done to reduce key staff turnover is absolutely going to be worth the time and energy. Any formal programs that we're seeing out there, anything that is going on, or any of the possibly the flex programs focusing on this area of retention, recruitment?
Terry, this is Pat, and I'm seeing more interest in the Joe Ties type of program that helps booster the employee and help them to feel better about themselves. And probably ties in a little bit what Angie just said. And I've seen that over the last year or so growing. I don't know necessarily to keep more nurses, but just to improve the morale and interest in the hospital. And I think they're seeing that it pays off in the patient satisfaction. And you've seen Brian Lee's and all that stuff. 5 years ago, I wouldn't see the hospital spending their money on it, but I'm seeing them spend their money on that now.
And that's interesting because they probably have less available money given all the other
Right.
demands, electronic
But
health records.
they're making that an effort. They're doing some of the commercial, and then they're trying to do some of their homegrown stuff. So that's a change, at least here in Illinois.
One of the programs that's out there that's kind of designed to focus on the employees and change is the Studer program. And as some of you may know, the Studer programs have come to us and asked us to advise them on how they could bring their programs out to rural hospitals more effectively. And as I've looked at the data and the information and just my own direct experience with Studer, there's a significantly lower turnover rate. There's a huge focus on employees and staff satisfaction. They strongly recommend kind of measuring staff satisfaction because what I've found also through the business reading that I've done, there's a very strong and a two-way correlation between staff satisfaction and customer satisfaction or patient satisfaction. In other words, if the staff is happy and just basically motivated, it inspires confidence in the patients. And when I looked at another research study I did is that one of the major determinants of how a patient would rate the quality of the staff has to do with how happy the folks seem to be and how they work together as a team. So they lose confidence in the hospital if the staff not only tends to be grumpy, but tends to be grumpy with each other. They don't have to be grumpy with the patients. If they don't look like they're getting along as a team, from what I've read, it really diminishes the scores in the patient satisfaction side of it as well. Conversely, what we found is that if customers or patients are satisfied, it drives up the retention of employees and staff satisfaction scores as well. So those, one of the best strategies for getting better HCAHPS scores would be focus on how you support your teams and how you basically kind of invest in your people. Anything else on the culture side? So in essence, what Studer has agreed to do is to significantly reduce their rates. And I know there's an experiment going on, I think, right now in Hawaii, but they're trying to find a way to bring their services out, from a lower cost standpoint. We're doing exactly the same sort of negotiation or conversations with the with other folks, so I think as we're looking at ways to bring out these resources, whether they're organizations like Studer or Baldrige. Baldrige is also adopting a new model that will be specifically designed for smaller rural hospitals, and hopefully I think some of you have actually been advisory on that piece. And again, it's nothing that's going to be mandated to the state for the Flex program. It's simply going to be kind of a means of a tool, a resource that'll be available to both the Flex programs and hopefully to the hospitals as well. some of you had, so those, we've hit kind of the biggest pieces on this list. Obviously, another high-ranking one was the leadership development and management education support to improve overall COP performance. And then the provision of direct technical assistance to critical access hospitals. Melissa, you've been looking at perhaps providing some direct TEA. How is that going in Arkansas? I mean, it's Missouri.
Slowly.
Okay.
I've gone out and directly talked to, I guess it's been about 12 CEOs and their board members. And then we also provide scholarships for leadership development for those people every year. And this year we actually increased the amount that we gave them. Not all hospitals take advantage of it, unfortunately. There's money set aside for everybody to use that, but not all of them take advantage. It's those high-performing hospitals, as usual, that actually take advantage of it, and those ones that really probably need to use it don't.
Okay.
And they're also the ones I have a hard time getting into.
Yeah, which is just amazing in its own way, but not all that surprising, I guess, when you really look at it. The hospitals that need the help the most very often are the ones most reluctant to accept it, which is probably part of the reason they're in that situation to begin with.
Right, and it's not just me. You know, I work really closely with our hospital association, and they have the same problem. And our hospitals, if they're going to listen to anybody, it's usually the hospital association. And you know, they have the same problem with the same hospitals. So it's not just me. I think it's just the culture at those hospitals.
We've got a couple of any final thoughts on this, or anything that you might be doing in this area that you'd want to share with the rest of the group? Anybody else? Well, let me see here. We have another